Okay, so I think we're at a point where we'd love to have comments and questions from the audience, if you'd like to come forward. Just identify yourself, and we'll start right here on my left.
Okay, I'll use my medium voice. Okay, that's fine. My name is Amjad Riyar. I'm actually from the state of Maryland, as you can hear from my Maryland accent. I'm a hospice and palliative medicine physician, internist by trade before that. And I have been passionate about, on my individual basis, my wife does not agree with that, but I've been passionate about palliative medicine by itself, given that it's complex and it's part of the hospice process. And through that, I actually got inspired to, 4 years ago, initiate the effort to do a palliative care legislation. Now, I'm not someone who proposes legislations every day, but I felt compelled that that was the right thing to do. And I did the proposal, and it went through, and legislation was discussed at the state of Maryland, and it became law 1.5 years ago. So I'm proud of that because I believe it's going to serve larger population down the road. Now, moving forward, we have conversations about hospice and end-of-life care, and palliative care gets blanket kind of into it. What my question is to Dr. Conaway, specifically, what CMS is doing to actually implement or integrate palliative care into continuum of care, just palliative care, not hospice and palliative care. Thank you.
Yeah, so thank you for the question, and thank you for your advocacy work, by the way, as well. I think advocacy broadly matters a lot. We do talk about palliative care separately from hospice as well. I always worry if I mixed at all during the conversation, I apologize. And I'd say on the palliative care front, it's everything from our physician quality programs, which are incentivizing asking about these issues, to around clinical standards around certain settings and making sure in some of these settings where palliative care issues come up that there's a team environment and a focus on palliative care and enabling care choices. To, in our broad payment systems, we're trying to incentivize care coordination activity and focus essentially care coordination activity and engaging patients in new ways and what's the appropriate payment for that. So, and many of those touch on palliative care issues as well. So a few thoughts, and happy to have more dialogue.
Thank you. I'd like to call on Joanne Lynn, who's taught me everything I know about palliative care and will ask everything I forgot to ask.
It's following Jonathan Swift. I have two modest proposals that I'd love for you to respond to. First is that when we use the term population health, at least with regard to very sick people, and probably very sick people who are old, since most of us get very sick when we're old, that we think about it geographically. Why are we thinking population health as the population that happens to come to a doctor's office, or happens to get insured with Aetna? Why don't we think about the population of Washington, D.C., and are we doing better or worse? And are we leaving people behind? As you get old and sick and frail, you're really tied to your community. Mm-hmm. And you can have a hotshot hospital, and if there's a year-long wait for Meals on Wheels, you're stuck. So, why don't we start thinking population health geographically, at least for this population? That's one. And the second is, why don't we simply reinterpret the god-darn consent process for hospice? There is no curative care. They're turning down nothing. So, accept hospice as a program, but there's nothing to turn down, because if there was anything curative, you'd have for sure taken it. So this idea that there's curative care was built in an era when we really thought that burning out stuff with radiation was going to cure you. There's 80% of the people in the hospital today are going to leave with the same illnesses they came in with. In fact, the same illnesses they had 2 weeks earlier. We aren't curing very much anymore. It's really nifty when we get to, but mostly we're helping people live with bad illnesses. So just reinterpret the hospice rule and you've got the concurrent care.
Are you speechless? No.
I wasn't sure if that, no, and I'll take the first one more if that's okay.
I'll take the first one.
And we've talked about this, and I've also learned a lot from Joanne. So we agree on the population aspect. Both, we have an innovation center model we're working on that would be a geographic attribution model that we've talked about, publicly accountable health communities. And also in our core payment programs, we're working on measures that could be implemented at a population level and attributed to be honest, some providers that may or may not think about their community holistically. But we want providers to think about those community integration aspects.
Yeah, I think the definition of concurrent care is one that creates a mindset, and it's what I was alluding to earlier when I told you about the research we did back in the late 80s, early 90s around the situation in the ICU, where if we would have had a palliative care program and the opportunities to say, we understand that as a family member you believe your loved one would want all this done, but at the same time, can we introduce steps to help with the psychosocial issues, the family issues, and really work towards what is part of a comprehensive palliative care program. I think in many ways, over time, it would have been enormously helpful for everybody and certainly provided necessary comfort.
Great, thank you.
Hello, I'm Marion Grant. I'm an assistant professor at the University of Maryland in the School of Nursing. And I've been a palliative care clinician and educator for the past 10 years. But this year I'm in Washington doing a Robert Wood Johnson Health Policy Fellowship.
Great.
And I'm a staffer on Capitol Hill, where I was interested in learning that Medicare Advantage is becoming a growing plan. More and more people choose that, especially people who are new to Medicare. But then I just realized, or found out, and maybe I'm the only one in the room who didn't know this, that you have to give up hospice, or you don't get hospice as part of most Medicare Advantage plans. And we had a beautiful briefing a couple of days ago, and somebody spoke about Medicare Advantage, and I said, what about hospice? And they said, we don't do that. But apparently, some people do that. So is there a way more people could do that because this is a growing program, or am I missing something?
You want to speak to that?
I'll start, but you probably will have more to add. As I think you'll hear, there's MA plans that deal with these issues effectively. There has been a question, do we need an innovation center model that allows that to happen even more broadly in Medicare Advantage? So we're taking a look at that right now, and what could, and that is a potential innovation center model to think about how you would more effectively incentivize both palliative care and hospice care in MA.
So within our Medicare Advantage program, which is growing, the hospice portion of that is dealt with as any Medicare member would receive their hospice care. That's part of how the plan has to operate. I guess that's by statute?
Right, so we would have to waive said statute.
So it would have to be waived.
Yep, this side.
Yes, hi there. My name is Rob Razak. I'm a palliative care physician at Johns Hopkins School of Medicine. My question is regarding palliative care, if you want to bring it out to an outpatient setting, let's say home-based palliative care, one of the major issues is getting funding for chaplaincy and social workers and psychiatry. These patients have a lot of physical and psychosocial needs.
That's right.
And but there's no payment for the right staffing.
Yeah, I mean, I'll maybe just to begin that discussion and then go around. This, you're absolutely right. This was one of the issues certainly that we spoke about in our committee, the need for social as well as medical services, and we defined both of those very broadly. As I alluded to earlier, medical wasn't just doctors, it was the entire portfolio of providers, and social is the part that's really missing in this country. I mean, we spend less on those social services in the United States than virtually any other developed nation, and it's a key part of the quality of life and indeed the quality of death. How you pay for that is one of the issues that everyone ultimately comes to. Our thinking, perhaps naive, was that if you ultimately begin reducing unnecessary medical expenditures, you will have more to put into social services. It may be that you don't have a new net overall savings, but at least you wouldn't be spending more, or you'd slow the curve and be providing better quality of life and quality of death care.
I do want to put in a plug for hospice, because I know it's a beleaguered provider at the moment, but it is, and Patrick's referred to statute a number of times here, it is our only interdisciplinary team-based statutory care. So it's an important piece not to lose.
Yeah.
And the challenge is really what I described before, which is, in theory, if we had integrated care systems, delivery systems in a community, if we had mechanisms to fund that evenly, it would, I think, solve many problems. And in fact, what we see today is a patchwork approach where some of the psychosocial care that is received for an individual comes from church-based or community-based organizations which live hand-to-mouth based on donations and contributions. You know, the poster child of that is the Ronald McDonald houses that exist on many campuses where there's a children's hospital caring for kids, for children with cancer. And I can tell you, in my former life, we supported that Ronald McDonald House, as did the community. But it's not fully integrated. It's a patchwork, and I think more and more we have to work towards really making this seamless as opposed to the way it is today.
And you know, the other obvious point is, while we're talking about these challenges with regard to advanced illness or end-of-life care, they're emblematic of all the problems that exist in our current healthcare system. It's not really different in other areas, and these are the needs that have to be served if we're really going to move forward successfully as a nation. We should go to the side.
Paul Tatum, I'm with Hospice Compasses. Dr. Conway, we had a nice meeting with your team, fantastic team, and appreciated that yesterday. I wanted to frame my question again with a patient who's in mid-Missouri, a rural area, and they're not in an ACO area. They don't have a managed Medicare program. This person's frail. They've got multiple chronic illnesses. They have the problem that they're not eligible for hospice. Their main goal is they want to be home. Like Dr. Gawande said, if healthcare's purpose is to help wellness, and he talks about how with aging you get happy unless you're institutionalized, we want to keep him happy. The home-based primary care program within the VA has phenomenal data, and Dr. Tommy Eads has published that, I believe, in JAGS. And I'm wondering if we could talk a little bit about the independence at home. And so my crazy innovation, I'd like to call it innovation, maybe you'll say it's crazy. Where could we find, if independence at home shows getting people what they want at a reduced cost with improved quality, where in the world could we find an interprofessional team that exists already across America? And wouldn't that be an innovative way to get around the 6-month prognostic limit of hospice? Could hospice become the independence at home team member?
Thank you for the question on independence at home. A terrific model. We are working on releasing the results publicly soon. We've said publicly that they're promising. So it is, you know, a model that we think has real potential to improve quality and lower cost. You actually ask the question that people don't often ask. So then to scale that program up, which interestingly this one, the authority is not the innovation authority, so Congress would need to scale it up, but there's a lot of interest in Congress in this program, and it builds on a lot of the learning from the VA, as you said. There is this issue, do we have the right integrated teams across the country? Which I think is a real question. Others may know more than I do, but my worry is when it's successful and we're ready to scale, we may hit a barrier, at least some places, especially, for example, potentially in rural areas where we don't have the right support and healthcare workforce to implement that we need. So I think, and I know that was part of the report as well.
I agree with you, and I think this was, again, another topic that we at least considered in having virtual connections of services where real in-person doesn't exist. But this is true not only, of course, in palliative care, but when I also co-chair the Committee on Pain in America for the IOM, this is a huge issue in terms of pain management once you get into spaces where there are not pain specialists or qualified. Yeah. Okay.
Hi, Jeff Cohn, former oncologist, moved into quality patient safety. In general, I'm more of a believer in focusing on assets and carrots than sticks. These days, there are people who can do the sorts of treatments that we're saying don't provide value, and they themselves get rewarded for bringing more patients into the hospital, providing chemotherapy closer to the end of life, et cetera. So in addition to creating incentives to reward beneficial, virtuous care, anything that we can do to disincentivize the sort of practices that we're looking to get less of.
Pay less.
I mean, I'll start just briefly, although it is a bit more of a carrot than a stick. But actually, let me use a disincentive and an incentive example. I think on the disincentive side, as you know, we moved to hospital value-based purchasing and physician value-based modifier, et cetera, and they all have cost metrics and episodes of care. Readmissions is another disincentive example. I think we are seeing investment in a larger spectrum of care and thinking about inappropriate care. Certainly we need more targeted interventions, et cetera, and it's a pathway that we have more path to go, if you will. On oncology, because I didn't mention this, we recently announced an oncology model that's an episode-based payment model where we put in per member per month fees into oncology practices, but they're incentivized to decrease total cost of care for an episode of care. You know, we think that's, once again, could be a patient-centered model where patients are making very active choices that are evidence-based with their oncologist and shifts the financial incentives that are in oncology at times today.
I would add, and I referenced this in my comments earlier, the ability to collect quality data based on outcomes that really references what the process of care, where it winds up for an individual patient. And I think in many ways that addresses some of the issues that you just raised.
We have about 7 minutes, so we can potentially get through all the questioners if you ask short questions and we give short answers.
That's a lot of pressure. This is Katie Barnett with the Elder Care Workforce Alliance. Our coalition was formed around another IOM report, Retooling for Aging America. And I had a question about the Aetna program, and I wanted to know how you ensure that your care teams, your interdisciplinary teams, are trained in geriatrics and palliative care.
So our teams are made up primarily of nurse case managers who are trained in the work of palliative care and working with patients in the end-of-life program, we call our compassionate care program. They work collaboratively with individuals that are not employed by Aetna on the provider side, and it could be nurses, physicians, social workers, and others who are actually providing the direct patient care. But their job is really to coordinate, and they do interface significantly with the patients, and either by phone or even in person. But a great deal of the work is not being done by Aetna employees, but by others on the healthcare team. I don't know if I answered your question.
More or less. I'm just wondering, when you're reaching out to these other providers, if you're ensuring that the folks you're partnering with have geriatric competency.
Yeah. Well, that I can't answer, because I think it really is individualized to who's involved in the direct care of the member or the patient. But that's what these nurse care coordinators do day in and day out, is either by phone or in person provide that coordination of care.
Yes.
Rosemary Lillis, chaplain, Barnabas Health in New Jersey. Nurse, social worker, board certified chaplain. I collect master's degrees. And what I know is that I learned more about having respectful conversations with folks about what gave meaning and value to their life, ultimate values, in my chaplaincy training at Sloan Kettering and Lenox Hill, those places. But yet what I see, I appreciate the incentives to include professional spiritual assessments and care, but we are not reimbursable. Right. And I see many opportunities lost to use the clinicians most trained to have end-of-life conversations with folks. We're already trained, but we're not the ones that are funded or enabled to do it. So.
Well, and again, just to not to sound like a broken record, that's how it is today. But again, as we move more towards integrated delivery systems, and I'm proud to say the place that I ran and then left to join Aetna had a large chaplaincy program, and that's in fact where our staff spent their time. That was part of the job. And it was also to train as well. And I think that if we can move more and more to these integrated platforms, there are the financial resources to pay for those services. But again, in the current structure, it is enormously difficult for all the reasons that we said.
Hi, I'm Pat Bomba. I'm a geriatrician and a dinosaur. In most of my life, I've
and
spent
a fellow committee member.
Member of our team.
Right.
Member of the committee. I've spent most of my life in private practice taking care of frail elders and have been in all sites of care. I was the care transition that doesn't exist today. My current work, aside from being on the committee, is I lead New York's MOLS program, and I'm a member of the National Pulse Paradigm Task Force. And today we talked about advanced directives, but we really didn't talk about medical orders, which are the key end product to make sure that people get what they want. And I want to go back to interoperable advanced directives and medical orders. We're talking about EMRs. I am leading the EMOLS program in New York State. We have 630 nursing homes where a bulk of people are. They all don't have EMRs. And so if you take Phil's idea of going to CVS, we need to have internet-based solutions and not hospital EMR solutions. And so we designed our program to have a standardized clinical process, team-based approach, so those that are trained can do the conversation, have the ethical framework, and produce not only the MOLS form, but a copy of the discussion across care transitions. We're starting to see some benefits of honoring quality, honoring individual preferences, and some cost avoidance. But getting the dollars to support something innovative is another issue. Yeah. My question to you, Patrick, and anyone else is, how do we move from looking at meaningful use, checkbox advanced directives, to potentially looking at something that was in high tech initially in the law that said we want to have electronic prescribing, and it came to all solutions. Can we have a solution that says we want to have advanced directives and medical orders available everywhere?
So, I'll start. Sorry, didn't mean to interrupt the applause. Yeah, I think you hit on a key issue. I mean, the Act, as you know, had direct incentives for hospitals and physicians and clinicians, but not in the post-acute or other arenas. This has created this challenge where we don't actually have the basic infrastructure in some of these settings, as it sounds like you know incredibly well, probably better than I. And so then I think our collective challenge is, you know, what are the incentives to build some of that infrastructure? What would be the standards to implement? You know, we have done some work with the national coordinator on trying to support templates and standards around post-acute care, electronic health information exchange. But I think this is an area where, you know, there is a reality that the program being set up around hospitals and physicians, clinicians primarily, drove adoption in those settings. And unfortunately, we are not caught up, if you will, in any of the other settings of cares, which hinders actually the record moving with the patient.
It also hinders innovation for a model like ours because people are looking for meaningful use. And the last I looked for meaningful use 3, it's still checkbox, and potentially for care coordination, you may see medical orders. So I guess my question is, how could we move that forward?
Yeah, no, and we should certainly talk more after. I think in the short version, you know, I think we are going to try to push in Meaningful Use 3 and some other rules to move this forward in terms of exchange of information and engagement across post-acute care settings and other care settings, and happy to talk more about it.
So we should continue afterwards because we've got one last question and then we need to move on to our presentation.
I'll try to be brief. I'm Marcia Levittown. I'm originally a pediatric critical care doc and turned palliative care in '93. Take care of adults too. And I live in Houston, which is the 4th largest city in the United States with a 90-mile radius. And, you know, I'm concerned about access, whether you're in a densely populated, highly trafficked city like Houston, or whether you're in West Texas or rural Missouri or any other place, and I'm worried about workforce issues. So my comments that I'd like you to comment back on is very expensive and prolonged to generate a physician. It's much less expensive to generate PAs and NPs. I don't see that we're generating a lot of those. And then we have a lot of disincentives for people to go into geriatrics and palliative medicine because they're not paid very well, and the cost of becoming a healthcare physician is extremely high, currently about $250,000. And so the incentives are not aligned properly for people to go into this primary care or primary care subspecialty type thing. So they're going to generate a lot of neurosurgeons and cardiac guys and all that stuff. So my wonder is, how do we better create the educational pipeline and incentives for people to go into this field, and are we working on some solutions in those directions? Thank you.
Yeah, I don't know that there's an easy formula, although I totally agree with you. When I was in my role as dean of a medical school and the plea came to increase the number of physicians being trained in this country, Hal may have gone along with this, but I said no, because I really did not believe that we needed to put our emphasis on training many more physicians. I really believe we need to expand our services through care provided by nurse clinicians, practitioners, PAs, other providers. That to me seems to be a much wiser way to solve a lot of the problems that we have before us, and probably more economically sound as well. And I'm going to take the last word on that because we do have to end this session. So we won't have a debate on it because we really do need to move on to the next one. Okay? All right, thank you very much.